Hello viewers, welcome to my YouTube channel. Continuing our series on common surgical emergencies, today we'll be understanding and discussing a very common surgical emergency seen in young males, and that is a case of testicular torsion. Now, it is one of the commonest surgical emergencies which as a resident or as a surgeon you would be encountering in your clinical life. Now, what exactly is the demographics of testicular torsion? Now, it occurs generally in a young patient. Most of the patients are between the ages of 12 to 18 years. In fact, it has been found by various studies that 70% of cases of testicular torsion would occur between the ages of 12 to 18 years, with a peak incidence at 11 to 13 years of age. It can occur even in infancy and also in older life, though its occurrence in the elder population is slightly less as compared to young patients. It is not uncommon and it can occur between different studies have shown in different geographical locations that it can occur between 1 is to 4,000 males to about 1 is to 10,000 males in different studies. Now, let us understand what causes testicular torsion. What exactly is testicular torsion? In a common term, if you want to understand, testicular torsion is a rotation of the testes on its long axis along the spermatic cord. And because of this would lead to obviously a compromised initially the lymphatic flow, followed by compromised venous return, and ultimately the arterial inflow is also obstructed, leading to the danger of testicular ischemia, testicular infarction, and gangrene or necrosis of the testes. Now, all this sequence of events would occur over a very short period of time, and we will try to understand in our subsequent slides why timing is very important here in management of this very common condition. Now, before going into that, let us try to understand what is the predisposing anatomy which would lead to the development of testicular torsion. Now, it is not commonly seen in all the males, but there has to be some predisposing factors which would lead to its development. Now, if you see here on this chart, the pinkish line which is seen here is the tunica vaginalis. Now, this tunica vaginalis is the covering of the testes. It has two layers. It has got a visceral tunica vaginalis and then it has got a parietal tunica vaginalis. How does this tunica vaginalis develop? It develops when the testis descends from its position in the abdomen towards its descent into the scrotum. There is a fold of peritoneum which precedes the descent of the testes, and that fold of peritoneum is known as processus vaginalis. Now, as soon as the testis reaches the scrotum, this processus vaginalis, which initially was communicating with the peritoneal cavity, it closes and it loses its contact with the peritoneal cavity, or what we call as obliteration of this processus vaginalis, and whatever remains forms the covering of the testes. This part of the processus vaginalis, whatever remains once it loses contact with the peritoneal cavity, and that forms the part of the covering of the testes, and this is known as tunica vaginalis. Now, this tunica vaginalis, normally if you see in the first diagram on the normal side, it covers the anterolateral surface of the testes. And what exactly is this bell clapper deformity? Now, this is the deformity which would lead or which would predispose to the development of testicular torsion. Now, if you see the bell clapper deformity, here the tunica vaginalis not only encircles or covers the anterolateral surface of the testes, but it also extends posterolaterally also and goes and covers a part of the spermatic cord. So what we call as high insertion of tunica vaginalis. Now, because of this deformity, it is likened to a bell and a clapper. So because of this deformity, the testes is relatively mobile and it can easily torse or twist on the long axis of the spermatic cord. And this bell clapper deformity is one of the commonest deformities, the anatomical deformity, which would lead to the development of testicular torsion. We would also see the types of testicular torsion, the intravaginal and extravaginal testicular torsion subsequently. But this bell clapper deformity or anomaly would lead to the development of intravaginal testicular torsion. That means the rotation occurs within the tunica vaginalis as seen in the third diagram here. So this is the bell clapper anomaly or bell clapper deformity which predisposes to the development of testicular torsion. Now continuing our discussion on this predisposing anatomy, this bell clapper deformity is generally bilateral. This you must understand. It doesn't occur in a unilateral way, or it doesn't occur only in one testis. If this deformity is present in more than 80 to 100% of cases, this anomaly would be bilateral. So what is the implication of this, or what is the significance of this? Again, we'll subsequently discuss about it. It's bilaterality leading to what important step in the management. Now, because of the mobility of the testes due to high insertion of this tunica vaginalis as shown in this diagram, in testicular torsion, there may be a horizontal or a transverse lie of testes as shown in this diagram. We have already seen that this bell clapper deformity is mostly bilateral. It can also be associated with undescended testes. And what predisposes, another important thing, what predisposes to development of testicular trauma is trauma to the testes. Trauma to the testes, and also any unaccustomed vigorous physical exercise. For example, a person going to the gym and suddenly lifting heavy weight and coming to the emergency department with sudden severe lower abdominal and scrotal pain. Always testicular torsion in a young patient should be suspected. Now, these are the types of the testicular torsion which I was talking about. As shown in this, what we see in bell clapper anomaly is mostly intravaginal torsion. That means this bluish shaded area is the tunica vaginalis, and the torsion occurs within this tunica vaginalis. That is known as intravaginal torsion. If the torsion occurs outside the tunica vaginalis, then it would be known as extravaginal torsion. Now, most of the torsion which occur with bell clapper anomaly would be intravaginal torsion. Now, let us try to understand, having understood the anatomical abnormality and the predisposing factors which would lead to the development of testicular torsion, let us try to find out how these patients present or what are the clinical features. Now, the most common clinical feature is a occurrence of sudden severe pain, which has been described as 10 on 10. It occurs generally in the lower abdomen and in the scrotum. And the pain is so severe, and generally it is aggravated or preceded by the chronic straining or sudden straining while passing stools or coughing, a bout of cough. It can also occur due to unaccustomed sudden lifting of heavy weight, like the example I gave you in a gymnasium where a young patient may develop sudden severe pain. It can also occur following a scrotal trauma or a testicular trauma, which could occur due to contact sports, or it could be in an assault situation. So the main predominant symptom is a sudden severe pain. If you examine the abdomen and the scrotum, there may not be any tenderness in the lower abdomen, but the scrotum over a period of time, within next hour or so, would undergo swelling. So there would be scrotal edema, there would be extreme tenderness in the scrotum, testicular tenderness, and the overlying skin may become slightly erythematous. There would be loss of scrotal rugosity also because of scrotal edema. Patient may also complain of nausea or 2 or 3 episodes of vomiting, which is generally self-limiting. It is not a persistent vomiting. If you examine the testes, apart from testicular tenderness, you may also encounter the transverse or horizontal lie of the testes, which is one of the important diagnostic or clinical feature of testicular torsion. Now, there is two important signs which, as a clinician, you must try to elicit, though the Prehan sign is unreliable clinically and may not be able to tell you exactly whether you're dealing with a testicular torsion or not. Now, what is Prehan sign? In Prehan sign, if you try to lift the scrotum, on lifting the scrotum gently with your hand, the pain in acute epididymoorchitis, which has almost similar clinical features like testicular torsion, the pain in acute epididymoorchitis would get relieved on lifting the scrotum with the palm of your hand. Whereas in testicular torsion, this would not occur. The pain would persist, or in fact, it may get aggravated. So this clinical test, the Prehan sign, would differentiate between the testicular torsion with acute epididymoorchitis, with which it can be confused clinically. Though I again would emphasize that Prehan sign should be elicited, but it is not a reliable sign, and the diagnosis of testicular torsion or exclusion should not be based only on Prehan sign. Another important clinical sign is the absent cremasteric reflex, which is seen in testicular torsion. Now, if you have a young patient who comes to you with a sudden severe scrotal pain, with swelling and with nausea and vomiting, there are few other differential diagnoses which may be confused with testicular torsion. And the most common we have already seen is acute epididymoorchitis, but generally it is associated most commonly with urinary tract infection, and many of these patients would exhibit the symptoms of UTI in the form of dysuria, increased frequency, and discomfort while passing urine. Similarly, if there is a history of trauma and development of scrotal hematoma, then also the patient would have a swelling and a tenderness in the ipsilateral or bilateral testes. A strangulated complete inguinal hernia. Complete means the hernia which has gone into the scrotum. If it gets strangulated, that means the indirect hernia. If it gets strangulated, then it can present as a swelling and erythema and scrotal edema of the affected testes or scrotum. And torsion of appendage of testes is another important condition, though not so common, which can be confused with testicular pain. So these are the differential diagnoses of acute scrotal pain and scrotal swelling, acute scrotal swelling, which should be ruled out in a patient with testicular torsion. Now, clinically, we generally take help of one scoring system, which is known as, for a mnemonic, it is a TWIST score. TWIST score basically is acronym for testicular workup for ischemia and suspected torsion. This is TWIST score. It's a 7-point tool to clinically evaluate any patient who comes to you with acute scrotal pain and swelling. Now, what exactly this TWIST score consists of? There are different points given for different symptoms and signs. The first one is the testicular swelling, for which 2 points are given. If you palpate the testes and if you encounter a firm to hard testes, another 2 points are given. Absent cremasteric reflex, which is one of the hallmarks of testicular torsion, would be given 1 point. Presence of nausea and vomiting, which may or may not be present, is given 1 point. And a high riding or a transverse lie of the testes or a horizontal lie of the testes would be given 1 point. If the score in a particular patient is between 0 to 2, there is a less likelihood of this patient having a testicular torsion. On the other hand, if the score is coming to 5 to 7, which is a high score, then very likely that this patient has got testicular torsion. So this scoring system, the TWIST score, can be used as an adjunct in the clinical evaluation of any patient who comes to you with acute scrotal pain and scrotal swelling. Now, there are few investigations which should be done, especially in a patient where diagnostic dilemma may occur. However, let me emphasize, because testicular torsion is an emergency which has a time frame attached to it, within which, if the surgical exploration is not done, patient can go and develop testicular ischemia, necrosis, and gangrene. That's why it is emphasized that on clinical examination, if there's a high index of suspicion of testicular torsion, then no time should be wasted in performing a surgical exploration if the Doppler studies or the ultrasound examination is not immediately available. However, if you feel as a clinician or as a resident that there is a sufficient time, the patient has come to you early, then ultrasound testes with Doppler should be done to rule out or include testicular torsion as your diagnosis. Now, if you do ultrasound testes, the classical sign which has been described is known as whirlpool sign, as shown in this diagram. The picture of ultrasound which shows a whirlpool sign. What exactly is this whirlpool sign? It is nothing but it gives the appearance of a whirlpool at the place where the torsion or the knotting of spermatic cord has occurred. It can also liken to sometimes a target sign. Secondly, on Doppler examination, obviously you would see a reduced or impaired blood flow in testicular torsion. Whereas in case of acute epididymoarthritis, the blood flow may be normal or may be slightly increased because it is an inflammatory condition. Now, the treatment here is of paramount importance. We have already seen that early treatment, timely treatment within 6 to 8 hours of onset of symptoms would prevent any irreversible testicular ischemia or testicular necrosis. That's why when any patient comes to you with acute scrotal pain and swelling, within 6 to 8 hours, all the investigations, clinical examination, investigations required should be done, and patient should undergo immediate surgical exploration. If it is done within this time frame of 6 to 8 hours, then there is very likely chance that testes can be salvaged. If the surgery is done beyond 8 hours, more likely, more than 80% of chance that most of the time the testes may have undergone irreversible ischemia and necrosis, and this may lead to the performance of orchidectomy, which is a very unfortunate surgery to be performing in a very young patient. Now, the viability of testes has to be ascertained during surgery. That means when the surgeon explores the scrotum and when it does the detorsion, and if the testes appears to be congested or slightly dusky, then the surgeon wraps the testes in a warm saline for at least, after detorsion, wraps it in a warm saline for at least 2 to 4 minutes and see the return of the color. If the testes is viable on detorsion, the color would return to normal within that time frame. However, if the testes remains dusky and cyanotic or congested or shows signs of ischemia or necrosis, then more likely the viability of testes is doubtful, and in such cases we may have to do orchidectomy as the only procedure. However, every effort should be made to salvage the testes. And what is the surgery? It is immediate surgical exploration, scrotal exploration, detorsion, and bilateral orchiopexy. Now, what is this? So once the detorsion is done, what is bilateral orchiopexy? Now, if you go back and remember that Bell-Clapper anomaly, the anatomical anomaly, I have already emphasized that it is present bilaterally. So very likely that this patient has got a chances of recurrence of testicular torsion in the future, not only in the same testes, but also he has got an increased incidence of chance of development of testicular torsion in the contralateral testes also, because it is bilateral. So what is this bilateral orchiopexy? So to prevent further recurrence of testicular torsion, three sutures are taken, and the testes is anchored from the base of the testes to the deeper layers of scrotum. That means 3 sutures are taken from the base of the testes and it anchors it to the deeper layers of the scrotum. Now this would prevent the torsion in future. So this is known as the classical surgery, the detorsion and bilateral osteopexy. And if done properly, the patient can have no evidence of further recurrence has been documented if this surgery is performed. With that, we come to the end of this presentation, the common surgical emergency. Continuing this series, I would keep on covering different types of surgical emergencies in future. If you like my video, please subscribe to my channel. This would help and motivate me to make more further videos for your benefit, and also like and share my channel. Thank you so much.